please.
Okay, good evening, my colleagues. I am pleased to welcome you to this webinar about neuroanatomy. And I use this opportunity to thank the Yemeni Society of Neurosurgery, the WFNS, the Pakistani Neurosurgery Society, and the Neurosurgery TV to organize this educational course in neuroanatomy. And today it is my pleasure to welcome Professor Baris Kucukyuruk. He is an assistant professor from the University of Istanbul, and he will speak today about microsurgical anatomy of the third, fourth, and sixth cranial nerve. So I welcome you all, and special welcome to Dr. Baris. So you can start, please.
Yeah. Thank you, Professor Al-Kuwaiti, for this nice presentation. And I would like to thank to the both World Federation of Neurosurgical Societies Young Neurosurgeons Committee and also Yemeni Neurosurgical Societies for this very beautiful meeting, hosting me. I feel honored. Thank you personally to all of you, and thank you to the audience. So I'll try to talk about the microsurgical anatomy of the third oculomotor nerve, fourth trochlear nerve, and also the sixth cranial nerve, which is the abducens nerve. So these are cranial nerves exiting from the brainstem. We see here from third to the 12th, except the first one and the second one, which is the optic nerve. Besides them, all cranial nerves exit from a level of the brainstem. This is the pons we see in the center, and this is the bulbus beneath it. So above the bulbus, just at the superior border of the bulbus, there is the third nerve exiting from the brainstem. And below it, through the pontomedullary sulcus, which is located here, exits the sixth cranial nerve. So between the third nerve and the sixth nerve, there should be the fifth nerve, which is a trigeminal nerve here, and there should be the fourth nerve, but which is the only cranial nerve which exits or originates from the back side of the brainstem. Except the fourth nerve, all the cranial nerves exit from the anterior side of the brainstem, while the trochlear nerve originates from the posterior side. So that's why we don't see it here. So let's look all of them from superior to the inferior. So at the superior border exits the third nerve, and in the inferior border of the pons exits the sixth nerve. This is the trigeminal nerve. There we see a cortical structure. A very tiny portion of the cerebellum is called as the flocculus. Just medial to it there is choroid plexus, and just medial to it there is foramen of Luschka, which is just bordered by the seventh nerve, eighth nerve, and the ninth nerve. So when we go to the medulla, there is the bulbus, there is the pyramid, and just between the pyramid and the olive, they are exiting the 12th nerve, which is the hypoglossal nerve. So we're going to focus on the third nerve, sixth nerve, and the fourth nerve in this talk. Why these three cranial nerves are focused together in all studies also in this topic? Because they exit from the brainstem, pass through the cisterns, and enter into the cavernous sinus by piercing the dura of the skull base. And within the cavernous sinus, they go through the superior orbital fissure to reach to the orbital space. So we're going to follow these three cranial nerves through their courses, step by step, and go into the orbit from the brainstem. Let's begin with the third nerve. So this is a brainstem axial cut of the mesencephalon at the level of the superior colliculus. This is the aqueduct. This is the interpeduncular cistern. These are the red nuclei And just posterior to the red nucleus and anterior to the aqueduct, there are oculomotor nucleus where this nerve starts. And through the oculomotor nucleus, the third nerve begins as the intramesencephalic segment of the third nerve, and then goes into the interpeduncular cistern as the cisternal segment of the third nerve. During its course, where it begins again in the interpeduncular cistern, the third nerve goes anteriorly and from medial to the lateral to reach the skull base. Through this course, it is closely related to the posterior circulation of the brain. Let's see this left side of the mesencephalon. This is the left hippocampus pulled down and the left mesial temporal structures. Just see the third nerve begins in the interpeduncular cistern. It courses anteriorly and from medial to lateral between the posterior cerebellar artery located superior to the third nerve and superior cerebellar artery located inferior to the third nerve. So the third nerve exits from the brainstem, and at the first step, it goes in between the posterior cerebellar artery above and the superior cerebellar artery below, and then goes more anteriorly and anteriorly to reach the skull base. Why do we need to know why the third nerve is located below the PCA and above the superior cerebellar artery? Because when we need to, sometimes we find the third nerve at its anterior point where it enters to the skull base and follow it backwards to find these vessels. So this is a right-sided Transylvian approach to the right internal carotid artery, right pecome, which is a fetal pecome here. Let's look closely. The fetal pecome exits from the right internal carotid artery and joins with the basilar artery to continue as the posterior cerebellar artery above the third nerve, and the superior cerebellar artery exiting from the basilar artery below the third nerve. So this is a very beautiful landmark that when you find the third nerve and follow it backwards, anything superior to it is the PCA and anything below it the SCA, superior cerebellar artery. But sometimes, since the third nerve is somehow squeezed at the where it enters to the skull base, we may need to open it to mobilize this nerve to see the structures more located deep inside. When we want to do it, we must remember that cavernous sinus, the venous plexuses of the cavernous sinus may extend until to the oculomotor cistern, which is a small pocket filled with CSF, but sometimes also the venous plexus of the cavernous sinus may extend here, and when we want to cut the dura located above the third nerve, it may bleed out, and we may be forced to gently stop this bleeding. Also, when we are here, we need to talk about the oculomotor triangle, which is also known as the Hakuba's triangle, which is the site where the oculomotor nerve exits from the brainstem, enters to the skull base. So in the oculomotor triangle, now after this opening, the oculomotor nerve becomes extradural by entering the upper portion of the lateral wall of the cavernous sinus under the anterior clinoid process here. And we may know the margins of the oculomotor triangle, which is as a triangle, as the name suggests. So there are three dural folds, which are the margins of the oculomotor triangle. The first one is the anterior petroclinoidal fold, which is extending from the anterior clinoid process to the posterior clinoid process. The second one is the posterior petroclinoidal fold, which is the first one is anteroclinoidal fold extending from the ACP to the petrous apex. The second one is the posterior clinoidal fold, petroclinoidal fold, which is extending from the PCP, posterior clinoidal process, to the petrous apex. And the third one is the first one I was fold, is extending between the posterior clinoidal process to the anterior clinoidal process, which is referred to as the interclinoidal dural fold. So anterior and posterior petroclinoidal dural folds and interclinoidal folds form a triangle where the third nerve becomes now, after the oculomotor cistern, it becomes the extradural. Why this is important? Because when we drill the ACP out, we're going to find the extradural portion after the distal dural ring, extradural portion of the internal carotid artery. Okay, let's give a break with the third nerve and look into the trochlear nerve, because now we reach to the skull base with the third nerve, and let's catch with the fourth nerve. So we found in the first slides, this is the right superior colliculus and this is the left inferior, right inferior colliculus. So at the first slides, there was a axial cut at this level to find the oculomotor nucleus at the level of the superior colliculus. And now we're going to see this yellow shaded area, which is the trochlear nucleus at the level of the inferior colliculus. So the left superior and inferior colliculi are removed to see this nucleus. And then trochlear nerve exits just beneath the inferior colliculus. This is the right trochlear nerve here and the left trochlear nerve here, and it goes around the brainstem to reach the anterior margin of the pons. Let's follow it. Let me first speak about this picture. So this is the cerebellum. The right cerebellar hemisphere is pulled backwards to open the cerebellar midbrain fissure. So this is the inferior colliculus of the right side, inferior colliculus of the left side, superior colliculus of the left side, pineal gland. So this is the quadrigeminal plate of the midbrain. So these are right superior and inferior colliculus, and just beneath the colliculus exits the trochlear nerve and goes around the brainstem to reach the anterior side of the brainstem. And let's now look to the from the right view to the lateral side of the brainstem. We see the third nerve above the superior cerebellar artery exiting from the basilar artery, and there was the PCA. It was cut down, but if it wasn't, it will course above the third nerve, while this SCA is below the third nerve, and SCA goes down, and here we see the fifth nerve, and between the third and the fifth nerve there will be the trochlear nerve. It originates inferior margin of the inferior colliculus, goes around the brainstem. But at the end, the importance of the fourth nerve is it joins to the free edge of the tentorium. In most of the specimens, or in most of the cases, it actually joins the free edge of the tentorium at the anterior margin of the brainstem or in sutural space, but in around 10 or 15% of the cases, it may join the free edge in very backwards, let me say at around the posterior margin or the mid portion of the brainstem. So we need to be careful when we cut the tentorium to show both the superior and infratentorial spaces. Sometimes we may need to cut the tentorium, but we should expect first to see and then cut the tentorium to preserve the fourth nerve. And let's see the sixth nerve. And this nucleus is known to be located or adjacent, just deep to the fourth ventricle. So in normal anatomy, we can sometimes see a rounded protrusion, the nucleus of the abducens nerve. I highlighted its location, but let's go to this slide. This is actually the fourth ventricle. So these are the abducens nucleus. So this is the left facial nucleus, and the facial nerve begins as the intrapontine segment of the facial nerve goes around the abducens nucleus and then goes to the cisternal as the cisternal facial nerve, and while abducens nucleus continues as the abducens nerve here. Okay. And the abducens nerve then exits from the brainstem and as the third nerve and the fourth nerve, where it joins to you see here the free edge of the tentorium. Also, the abducens nerve goes anteriorly and pierces the skull base dura to enter to the skull base. Let's follow these three cranial nerves together now at the roof of the cavernous sinus and within the cavernous sinus. So this will be a stepwise dissection in following pictures of the right-sided cavernous sinus. And this lateral wall of the cavernous sinus extends from the tentorium, free edge of the tentorium. It extends below by covering the lateral wall of the meccal cave and the middle fossa. This is the second nerve, the optic nerve. This is the intradural portion of the right internal carotid artery and the left internal carotid artery. This is the left optic nerve, and these are the left and right oculomotor nerves. This is the right trochlear nerve entering to the free edge of the tentorium. We don't see the sixth nerve right now, okay? So again, I would like to say the borders of the oculomotor triangle, which were the anterior petroclinodal fold extending from the anterior clinodal process to the petrous apex, posterior petroclinodal fold extending from the posterior clinodal process to the petrous apex, and interclinodal ligament extending between the ACP and the PCP. Okay. So the outer layer of the dura is removed to expose the cavernous sinus here and also the meccal cave. We see now here the third nerve entering into the oculomotor cistern, the fourth nerve coursing within the free edge of the tentorium. So they go together, and this is the fifth nerve here. Still, we don't see the right-sided sixth nerve, while this is the left-sided, but we're going to focus on the right-sided ones. So the third nerve and the fourth nerve are joining together to extend to the superior orbital fissure, which is located below the anterior clinoidal process. Let's go one more. Now we see the third nerve, the cistern is opened. Some of the dural linings are removed to better see the fourth nerve here going together to the superior orbital fissure. And when we go a little bit further by removing the cavernous sinus, now we see the right-sided sixth nerve going through the Dorellos canal, which is formed by the petrosphenoid ligament. So this ligament forms the roof of the Dorellos canal. So the sixth nerve courses within the cistern, pierces the dura, courses through the Dorellos canal to join with the third nerve and the fourth nerve. So the three of them together with the first division of the fifth nerve, these four cranial nerves go into the superior orbital fissure here. So this is the second division of the fifth nerve, and this is the third division of the fifth nerve, which we don't have anything to do here. Okay, I'm passing this. Just I wanted to show, because now I'm gonna see all of these cranial nerves from a medial side. Let's focus again to the cranial nerves entering into the superior orbital fissure. So this is the third nerve. When the Hakuba's triangle is fully opened, then we see the extradural oculomotor nerve, and also the clinoidal, the anteroclinoid process is removed here. So we also see the extradural portion of the internal carotid artery, which is between the distal and proximal dural rings. It's called as the clinoidal segment of the anteroclinoid process. So the third nerve, the fourth nerve, the sixth nerve goes more medial to the first division of the fifth nerve and also the first division. So these four together go to the supraorbital fissure. This anatomy may also be important in today's very extending endoscopic endonasal surgeries, because you can go basically not in nowadays. You don't go only on the in a medial route. You can also go inferior skullbase, and also with expanded approaches, we can even go to the lateral to the internal carotid arteries. So I think it's also good to know this anatomy I'm speaking on from an endoscopic point of view. So this is, again, we see from the medial side. Now we're going to focus on the right side. When we go a little bit close, we see the anteromedial triangle and anterolateral triangle between the first and the second divisions of the fifth nerve, and we don't see here the third division here, but this triangle is located between the second and the third division of the fifth nerve. So this is the superior orbital fissure, where the third nerve, sixth nerve, which is located now in this look, the most medial cranial nerve here is the sixth nerve, just above and a little bit lateral to it, covering the lateral margin of the sixth nerve. There is the first division of the fifth nerve, and above them, as a separate cranial nerve, there is the third nerve. Here we see the petrous and cavernous segment of the ICA, and also we see here these small nerve rootlets, which are the carotid sympathetic plexus. Also here we see the median nerve, which is a very important landmark leading us to the petrous ICA in endoscopic endonasal surgery. The similar view now on the left side. Again, now this is the petrous ICA, cavernous ICA. This is the proximal dural ring and distal dural ring. This whitish layer in between them is called as the carotid sheath. So proximal and distal dural rings are bordering the clinoidal segment of the ICA, and just distal to the distal dural ring, there is ophthalmic artery, which exits just at the beginning of the intradural portion of the ICA in most of the nearly 92 or 93% of the all cases. But just remember, about around 7 or 8% of the cases, this ophthalmic artery may actually origin proximal to the distal dural ring, which may be in the line of view or just in the dissection site during an endoscopic endonasal surgery. So we need to be careful about this 8% origin point. So also let's focus on this third nerve again, the sixth nerve here. Okay. And when we go a little bit down, we were now in previous pictures, we were focusing around this area. Okay. But also we need to remember in any endoscopic surgery, we can go down to the brainstem, to the middle and inferior portions of the clivus. So the sixth nerve originates, this is the pons here, this is the medulla. So this bony landmark is located just at the ponto bulbar sulcus, let me say, or inferior pontine sulcus, it's called in other literature. So the sixth nerve originates at the border of the inferior 1/3 and middle 1/3 of the clivus, and it both comes to the skull base by going superiorly and laterally to pass through the doralus canal and then through the cavernous sinus and then go to the superior orbital fissure. And after they pass through the superior orbital fissure, these three cranial nerves we're focusing today reach to the orbit. So the optic nerve, of course, enters through the optic canal, and all the others are coursing through the superior orbital fissure, but the most medial and inferior part of it may be called as the oculomotor foramen also. So what we see here is a complex, very complex structure. This cut is around the level of the, not exactly, but at the level of the annulus of Zinn, let me say. So let me just focus on these structures. This is the optic nerve, optic sheet, ophthalmic artery. So here the colors of the nerves and the muscles are very similar. Let me just outline them. So this is the superior, this is the lateral, this is the medial, and this is the inferior oblique muscles, four of them. Okay. So here the third nerve is already divided. The superior division of the third nerve adjacent to the superior oblique muscle, the inferior division of the third nerve adjacent to the inferior oblique muscle, and here is the sixth nerve, which is located just medial to the lateral oblique muscle, which innervates it, and there is the fourth nerve just at the roof. And these are the superior and inferior ophthalmic veins within the orbit. So this is the annulus of Zinn opened to expose the structures within. This is the optic nerve here. The anterior clinoid process is removed. Annulus of Zinn is opened. This is the optic nerve, and within the orbit, it goes as the optic sheet, and this is the third nerve, and after the annulus of Zinn, it becomes the superior division going to the superior op muscle, and the inferior division going to the inferior muscle. This is the sixth nerve, and this is the trochlear nerve here. So it's a very complex anatomy. Sometimes in the intraorbital anatomy, in real cases, we don't see this kind of anatomy because the fat tissue fills this area. But it's good to know that the trochlear nerve, the relation of the trochlear and the superior division, and the inferior division with the sixth nerve. It's good to know. And also the optic nerve goes all around in between them at the center of this anatomy. Thank you.
Dr. Baris, thank you for this very informative lecture. We enjoyed really the lecture. Usually, I agree with all of what you said. I just to add only the motor nerve is only not creating fibers from the oculomotor nucleus. He is also getting some fibers from the Edinger-Westphal nucleus, which are the parasympathetic part of the nerve.
Yes.
And all sympathetic, parasympathetic and somatic part of the facial nerve, they live together, the brainstem, and live together to reach the orbit. So thank you too much, Professor Baris.
Thank you very much, Professor, for this nice presentation and very nice picture to show us. Also, there is a small correction when you mentioned about the annulus of Zen. The muscles are the recti muscles, not the oblique muscles. Just correction.
Yeah.
Okay. So if anyone of the audience, if they have any question or any remark, please, you can ask directly or ask in the chat. I don't see here any questions in the chat. So, Dr. Mohammed Qadi, do you have any remarks about this wonderful presentation?
Thank you so much for all audience. It is important to apply the anatomical findings with the clinical findings in to look for pathologies of the nerves moving the eyeball. As observation, what I saw in my practice, especially should we pay special attention to the trochlear nerve pulsing, because it is sometimes difficult to distinguish or to diagnose trochlear nerve pulsing. So I saw a lot of children, they came with the tilting of the neck, and they were misdiagnosed to have torticollis. But when you examine these children properly, you will discover that the problem is not torticollis, it is not muscular problem, but it is trochlear nerve pulsing. So in this case, corrective surgery for the muscles of the eyes, it may help a lot. And some children, they go for surgery for torticollis, which is wrong. It is not a problem of torticollis. It is neurogenic problem involving the trochlear nerve. So it is a chance to make a hint for all practitioners to focus for this problem. Thank you too much.
Thank you.
Thank you.
Dr. Bas, I have a question for you, please. How during operation, as we mentioned and as we all know, that the trochlear nerve is in close proximity to the free edge of the tentorium. So how do you differentiate intraoperative intratrochlear nerve from the free edge of the tentorium while you're cutting the tentorium? How can you preserve it?
Oh, the first step of the preservation is to search for it, not where you are doing it. For that thing, you need to go sometimes more posterior, and at the posterior margin of the pathology, just say a meningioma, you need to see the trochlear nerve, search for it, find it, and then it's in most of the cases, it's always covered by an arachnoid. Okay. Sometimes, of course, the pathology, say meningioma, can pierce the arachnoid or destroy it. So when you go to the pathology at the free edge of the tentorium, the fourth nerve may be squeezed between the pathology and the tentorium. But again, the best way to preserve it is not go deep where the pathology protrudes most. So you need to go not at the tip of the tip of the apex of the pathology. You need to go posterior where the nerve is not squeezed, where you're gonna find some CSF, a cistern, so you can find that the nerve there, and then follow it anteriorly. It either enters into the free edge of the tentorium or squeezed between the pathology of the tentorium. So the best way is not to find it where you go directly, you go over the pathology. It's not the best way to find the trochlear nerve where it is squeezed between the pathology and the tentorium. You need to find it in a posterior margin of the pathology. You find it there and then follow it anteriorly where it joins the tentorium.
Thank you. Does anyone have any other questions for Professor Baris? I think the presentation was very clear and very thorough, and there is no much question about it, and no unknown points. Everything is
Dr. Ahmed, just a small hint.
Yes, Doctor.
About the trochlear nerve. So the trochlear nerve, when it leaves its nucleus, usually it crosses to the other side. So there is a crossing of the nerve. Just when it directly come out from the from the nerve nucleus, so it crosses to the other side. It is the only one of these cranial nerves which crosses to the other side after leaving the nucleus. Thank you.
Thank you very much. So I think there is no more questions, and by this I ask Dr. Mohammed Al-Qati to give the closing words of this webinar.
So I want to thank Dr. Baris for this very comprehensive and clear presentation of the anatomy of the third, the fourth, and sixth cranial nerves. We enjoyed really the lecture. We wish him all the best. And thank you for all audience. And I want to say special thanks to Dr. Ahmed because he is the person beyond these activities for a long period of time. So thank you too much for all.
Thank you very much, Doctor. And thank you, Dr.
Thank you,
Baris.
Professor.
So I
Excuse
think by
me?
this, thank you very much, Dr. Baris, for
Oh yeah,
your participation.
I as always, I feel honored, Dr. Ahmed. Thank
Yes,
you
we are honored by your
personally to you,
participation.
and thank you, Professor. Thank you so much.
Thank you so much.
So I think by this we can conclude our webinar and see you all, inshallah, next week with more presentation and more speakers, inshallah. See you all, inshallah, next week.
Bye bye.